Hello, my name is Bruno FAUTREL. I'm professor of rheumatology at Sorbonne University, Paris, France. And it's my pleasure to present you the latest data about the management and the diagnosis of Still's disease patients. As you know, Still's disease is a dual disease. It has been first described in children at the end of the 19th century. And actually, the description in adults was much later, during the 20th century, but the description was quite the same, with three main clinical symptoms: fever, spiking fever, skin rash, arthralgia or arthritis, and in addition to that, a huge inflammation in the blood, which was available not with George Still in the 19th century, but later in the description for the adults. The prevalence of the disease is not exactly the same, slightly more important, or higher in children, approximately 3 cases per 100,000 people, and less in adults, probably 1 or below 1 for 100,000 people. Very important to say, there is no sex unbalance. Women or girls are not more affected than men, as it used to be in other autoimmune diseases. There is no familial aggregation of the disease, and frequently it appears completely alone without any association with other disorders. So the four what we call cardinal symptoms, the four main symptoms are this one, with fever, spiking fever, with period without any fever. These spikes of fever are likely to happen during the evening. There is also the rash. Typically, it's a salmon pink rash, not very visible, concomitant of the fever, but sometimes it can be just urticarial lesion. You may also have a joint involvement, joint pain, inflammatory joint pain, and in some patients only, you may have arthritis, and for some of these patients, probably not more than 1/3, erosive arthritis. And finally, this biological symptom, very important, an increase in white blood cell count, mainly of neutrophils, associated with a high level of CRP, ferritin, on other biological or acute phase reactants. Many other symptoms are possible, actually. In adults, it's frequent to have a sore throat or odynophagia. It's also frequent to have myalgia, which is not so easy to identify in children. In addition to that, a lot of patients have enlargement of the lymph nodes or splenomegaly. Some pleural or pericardial effusion are possible. Chondritis have been also described, and very important, the possibility to have elevation of liver function tests, and in some patients it may lead to a fulminant hepatitis, so clearly it's something to be aware of. In terms of pathogenesis, what we know of the disease is this description of the disease. So at the origin, you have probably a genetic background, but actually it's not clearly described in this patient. But besides that, there is the need of, let's say, a second signal. It can be an infection. It can be a change in the cells. So you have the activation of pathogen, of PAMs, pathogen receptors, or danger receptors, the DAMs. And then you will have the activation of all the innate immunity cells, macrophage, also neutrophils, within the activation of inflammasome, and NLRP3 seems to be important in this disease. Since then, you have a huge production of IL-1 and IL-18. The two cytokines belong to the same family, and you have consecutively an activation of all the actors of the innate immune system, with a cytokine burst with a lot of pro-inflammatory cytokines that are secreted. In some occasions, you have also, as bystander, an activation of the adaptive immune cells, especially Th1, Th17 cells, but also NK cells, which seems to be quite important when there is a macrophage activation syndrome. And then you have an even higher level of IL-18, but also a very high production of interferon gamma, which is part of the mechanism involved in this complication. So it means that Still's disease is mainly due to an activation, abnormal activation or inadequate activation of the innate immune system. When you have macrophage activation syndrome, you're more in an hyperinflammation syndrome, which means that you have the involvement of both the innate and adaptive immunity. In terms of research, there are a lot of questions about the resolution of inflammation. You know that when you have the resolution of the inflammation, it's not a passive process. There is a secretion of lipid mediators or proteins that are involved in this downregulation of the immune system. And maybe in Still's disease, part of the explanation may be some deficiency in this mechanism of resolution of inflammation. In terms of diagnosis and management, I will now present you the latest recommendations that have been proposed. It has been just presented at the last EULAR meeting in June 2023, and it shared our common recommendation produced by EULAR, the European Society of Rheumatology, and PRESS, which is the European Society of Pediatric Rheumatology. The two leaders of the work were Fabrizio De Benedetti for the pediatricians, he is based in Rome, and me for the adult onset Still's disease. And what we tried to cover during this recommendation process is 4 main issues. First one, we are likely to say it's the same disease, but what is the level of evidence to say, yes, it is exactly the same disease, and then maybe we can use the same name for children and adults. Second, how to make the diagnosis, and especially how to make an early diagnosis. Third, what are the treatment options, and how can we manage this patient from a therapeutical point of view. And the fourth one was about complication, how to detect the complication, and how to treat the patient once the complications are here. So these recommendations have been developed by a group of experts, pediatrician, adult rheumatologist, patient partner, and also a methodologist to drive the process very strictly and to be very precise and efficient in the development of this recommendation. This recommendation starts with 3 overarching principles. The first one is that all experts, you see here the agreement, you see just here the level, the strength of the recommendation and the level of evidence, i.e. the data from the scientific literature that were at the origin of the recommendation. Here you see that what we said is that systemic GIA and adult onset Still's disease are the same disease, and thus they should be designated by the same and unique name, which is Still's disease. So we come back to the previous name, and it seems to us important to use this term nowadays. Why did we end with this conclusion? Because we looked in all cohorts, all clinical trials in which there was a description of the patient, and you see that here the prevalence of clinical manifestation, here in black the children, in gray the adults. The prevalence is very similar between children and adults in terms of clinical expression of the disease. We have the same on biological abnormalities associated with the disease. We have the same also for complication of the disease. So the prevalence is globally similar between adults and children. So it makes things really important to say this is the same disease. However, there are some differences depending on the age. You see here that the prevalence of the disease is higher for young children before the age of 6. After that, there is kind of a plateau, and it continues at the adult age. And secondly, the complication may be more important in very young children below the age of 18 months. You see here, especially the macrophage activation syndrome is much more frequent. Up to one over two patients develop macrophage activation syndrome when they are younger than 18 months of age. For older children or adults, it's around 4%. A second overarching principle is to insist on the fact that the treatment target, the therapeutic strategy should be based on the shared decision making with the patient or the parents when they are children. And it's really very important to involve the patient in this discussion. Second, the treat to target paradigm has to be applied for this patient, which is to adapt the intensity of immunomodulating agent to the disease activity, and then very important to carefully monitor disease activity and to check if the disease is controlled or not. And finally, the ultimate goal of the treatment is to achieve a drug-free remission. It's not a live treatment, it's a treatment for several months, sometimes several years, but at the end, the aim is to decrease, to taper, and then stop the treatment. And finally, we insisted on the fact that macrophage activation syndrome may happen and continue to happen despite our very recent treatment. It may happen at the time of the diagnosis, after a few weeks of treatment, or after a few months of disease evolution. In terms of diagnosis, we highlighted the four cardinal symptoms with a description of fever, more than 35 degrees Celsius for at least 7 days, and it's a spiking fever with some period of resolution, especially in the morning. The rash is salmon pink, transient, but urticaria may also be included in the possibility to make the diagnosis. Musculoskeletal involvement is usually due to arthralgia and myalgia. Arthritis may be helpful, but it's not necessary to make the diagnosis, which is very important in children because it was up to now mandatory to have arthritis to speak about celiac disease. Now we want to be very clear. Arthritis may happen, but it's not necessary to make the diagnosis. And finally, there is high level of inflammation and CRP and ferritin are probably the two main parameters that can be monitored. Just a word about arthritis, just to show you in this very recent study that it was in children, but in children, clearly if you make arthritis mandatory to make the diagnosis of celiac disease, you will have to wait, you will lose time before to start the treatment. The median time of appearance of arthritis is 1 month, far below the other symptoms associated to the disease. Finally, new biomarkers have been identified, especially serum IL-18 and serum S100 proteins. You know S100A889, which is calprotectin, but there is also the S100A12 protein. This biomarker seems to be interesting to make the diagnosis. However, there is not enough consensus in terms of threshold to use them systematically. But when it's available, it may be interesting to perform. And finally, many other diseases may mimic, let's say, celiac disease, especially malignancies, infectious disease, or other inflammatory mediated disease. And it's important to recall that and to say that there is a long list of investigation to perform, depending on the symptoms of the patient, to really be sure that the diagnosis is still disease. In terms of target, we define, as it has been done in children, but we extended that to adults, that the target is a clinically inactive disease, that is a disease without any, or a situation without any symptoms related to celiac disease, and with a normal ESR or CRP. Remission is not a point in time, it's a period of more than 6 months with clinical inactive disease. So clinical inactive disease is just a one-time point. Remission is the same over a 6 months period. We don't have yet a common disease activity measure for all the patients, but it will be on the research agenda for the coming years. In terms of target, very important to identify the different timings for the targets. So we use what has been already proposed in children by the CARA organization, but also by the PROKIN organization. And we just modify slightly to say at day 7 we want a resolution of fever and a reduction of CRP by more than 50%. At week 4 we want no fever, reduction of swollen joint by more than 50%, normal CRP, physician or patient global assessment less than 20 on a 0 to 100 VARs. At month 3 we want a clinical inactive disease with low glucocorticoid, less than 0.1 milligram per kilo and per day for adults, less than 0.2 for children. And at month 6 we want the clinical inactive disease without glucocorticoid. So really something to reduce the exposure of steroids of patients. In terms of treatment, the first thing, very important recommendation, NSAIDs can be useful at the time of the diagnosis during the investigation, but only a minority of patients will respond correctly to NSAIDs. Glucocorticoids are clearly efficacious, but the problem is that their long-term use is likely associated to side effects, and then this must be avoided. For this reason, we highlighted that the efficacy of IL-1 and IL-6 inhibitors are at the highest level of evidence, and then they should be prioritized and used to treat these patients. And this is all the studies that have been conducted in SGA or AOSD patients, a lot of different molecules, and actually the one for which we have a high level of evidence, no huge bias, are the IL-1 and IL-6 blockers, and you see here in these two meta-analyses that there is a significant effect of this molecule either in children or in adults. Very important message in addition to the previous one, IL-1 or IL-6 inhibitors should be initiated as early as possible when the diagnosis is established. So this is very important. These molecules are not only dedicated for people who are refractory to glucocorticoid, but they have to be used as soon as the diagnosis is made. Why did we say that? Because in two observational studies in which there was a comparison between people treated early with IL-1 or IL-6 blocker versus late, and you see here the threshold was less than 3 months or more than 3 months, or less than a few months, a couple of months, or several months. You see that the rate of clinical inactive disease is much higher when you start the treatment early, 92% versus 37% for IL-1 blocker, 54% versus 0% with IL-6 blocker. So to us, it's something very, very important to say that once the diagnosis is made, we have to start glucocorticoids and an IL-6 or IL-1 inhibitor. Finally, the maintenance of CID for more than 3 to 6 months without corticoid should lead to a progressive tapering of a biological demand, and then the easiest way to do that is to progressively space out the injections. In terms of complications, very important message here. The first one is whatever the complication, including macrophage activation syndrome or lung disease, it may develop at any time point during the disease course. So the physician have to be really very careful, and they have to screen the patient for this complication. Second thing, macrophage activation syndrome has to be considered or when you have a persistence of fever, splenomegaly, increase or rising ferritin despite the ongoing treatment, when you see a decrease of white blood cells count of platelet and hemoglobin, when you have rising liver function test, when you have abnormality of coagulation, increase or rising of serum triglyceride. And in this situation, macrophage activation syndrome has to be looked for. There are several scores that can be used to identify this macrophage activation syndrome. Up to now, no consensus to use one more than the other, but they all perform quite well. And finally, the treatment for macrophage activation syndrome include high-dose glucocorticoid, and in addition, we can use an anakinra, except if it's already ongoing, and other possibility are cyclosporine, with a huge experience in pediatric rheumatology with this compound, or there is a possibility also to use monoclonal antibody targeting interferon gamma, and there is an ongoing trial of that, so it can be also another option. So very important, a very aggressive strategy, adding glucocorticoid, anakinra, and sometimes emapalumab, or the anti-interferon gamma antibody, or cyclosporine. Lung disease, the new complication that we were not used to see 10 years ago. It has been first described in the US. And here what we want to identify is that it has to be screened by looking for some specific and not very intense symptoms: clubbing, persistent cough, shortness of breath, and you may also have some abnormal pulmonary function tests like pulse oxygeometry or DLCO measurement. And then the CT scan, high-resolution CT scan, is the investigation to perform to identify this complication. The first description here is coming from the US, when there were a patient with this subtle clinical manifestation, and then the CT scan, where there was mainly a thickening of the intralobular septa, but also some ground glass opacities in the lung. And when some biopsy had been done, there was the infiltrate by CD4 and CD8 positive cells. There was also in some patients pulmonary alveolar proteinosis, which is the accumulation of surfactants in the alveolar. And this really, when the inflammation in the septa are very important, it can lead to some fibrosis. Later on, European experience reported almost 50 cases. When you see the characteristics of this patient were quite interesting. You see that macrophage activation syndrome was observed in more than 80% of the patient. Clubbing was present. A large proportion of these patients are eosinophilia, but also very high level of IL-18. On the lung CT scan, there was this thickening of the septa, and important thing, there was an exposure to IL-1 or IL-6 inhibitors in the majority, but not all patients, which seems to indicate that there is a role for this agent. Another observation is the presence of HLA-DR-beta1 allele, and actually this is not, it's 25% frequency in still disease patient without complication, but in what was proposed as a DRESS syndrome, it was 80% of the patient, and in lung disease, it was even more than 80%. So here there is also something very important with this HLA, which indicates that there is not only the involvement of innate immunity, but also of adaptive immunity. So there are two hypotheses. The first one is that there is a drug hypersensitivity reaction. So the drug is the antigen leading to the activation of the adaptive immune system. And then you have the different manifestations. Another option is that you have the biological is just an effector of the change in the immunological in inflammation, it's a change in inflammation, with what was called a cytokine plasticity. When you block specifically IL-1 and IL-6, you have a shift in the activation of the immune system with the involvement of Th1 and Th2 cells, and then some other manifestations which were not expected when this treatment was not used. potentially there could be the role for some infection in this change in the orientation of the inflammation, and this has important implication, because in the case it's really related to the drug. In the, let's say, duress hypothesis, you have to stop the drug, but actually the experience in many pediatricians in the US, but also in Europe, is that when you stop this treatment, you don't change the evolution of the disease. So it means that maybe this compound had a role, but it's not an hypersensitivity to this compound. And thus the likely option to use is to modify the treatment, i.e. to add something in addition to IL-1 and IL-6 blocker, and to block T cells to avoid this activation of the adaptive immunity. So this has been translated in terms of recommendation to say that there is insufficient evidence not to use IL-1 or IL-6 inhibitors in patients, in new still disease patients at risk of lung disease. There is insufficient evidence to stop IL-1 or IL-6 inhibitor in patients who developed still disease lung disease. And finally, based on what we understand of the pathogenesis, we have to consider a T-cell directed therapy, so immunosuppressant therapy, like mycophenolate mofetil or rapamycin, which can be very powerful to block the adaptive immune system and to block the evolution of lung disease. Finally, the last recommendation to say that for these patients who are difficult to treat, there is a clear interest to contact the rare disease centers through the ERN VITA, which is the ERN, the European Reference Network dedicated to autoinflammatory disorders, and to manage these patients in collaboration with the most experts doctors that you may find in these centers. So in conclusion, still disease is now one unique disease, but it remains challenging, although we have very powerful treatment. The very important thing is that we have efficient strategy, but for some patients, some new medication are needed, and this is where the reference centers are very important to contact, especially because some clinical trials are ongoing with anti-interferon gamma monoclonal antibody, or with B-specific anti-IL-1, anti-IL-18 monoclonal antibody. So new possibilities for people with these very rare people with complications of the rare disease. And I will thank you for your attention.